So, hello, Professor Jonathan Valabhji, OBE. Thanks for speaking to me today.
That's a pleasure. Thank you for inviting me to come and give me an opportunity to talk about my last decade, an experience in the National Clinical Director role for diabetes and obesity.
Yeah, so we're here today to talk about your role and what you've achieved with your time at NHS England in your role. So, how long have you been in the role? When did you start?
So I was appointed in 2013, actually. So my first day in post was the 1st of April 2013, which coincided pretty much with the sort of first implementation of the Health and Social Care Act 2012, which of course did many things, including creating the entity, the arm's length body that is NHS England. I was appointed in the midst of lots of infrastructure changes, really. But in some respects, there were many new things happening, new organizations, new approaches. And so it was, I think, a real advantage being there at inception of new things, really. And I was able to develop in my own national clinical leadership role as NHS England developed itself, really, which I think was an advantage, although a little daunting initially, I recall.
Yeah, I bet. So, over your decade in the role, tell me your 5 biggest achievements.
So I think the thing that I am most proud of is the first major piece of work that we landed. So I came from a place really when I first started. I was a one-man show. I had no team, I had no resource, I had no work streams when I was first appointed. And I had to work away at achieving all of those things. And the first thing to land, I hope will have a real lasting effect and legacy, which is the NHS Diabetes Prevention Programme. We managed to secure funding. We had managed to land a stated ambition in the first policy output, if you like, strategic document that the NHS published after my appointment and following the sort of creation of NHS England, and that was called the 5-year forward view. And within the 5-year forward view strategy document, we said very clearly that we intended to achieve a position whereby England became the first country to implement at scale a national evidence-based type 2 diabetes prevention programme. And having written that in the document pre-2015 general election, that was actually, we were successful in achieving the resourcing following the general election, actually in the ensuing comprehensive spending review, that saw to it that we were able to implement and roll out the programme nationally, which was an enormous undertaking and has been. We're now sort of 8-9 years down the road. England became the first country to achieve universal geographical population coverage with such an evidence-based type 2 diabetes prevention programme. We rolled the programme out in 3 waves. We started in early 2016-17 financial year, and by summer of 2018 we became the first country in the world to implement such a program with universal coverage, which was lovely. That coincided with the NHS's 70th birthday, which made for a nice narrative and saw me on the telly once or twice, which is quite nice. So having achieved universal sort of population coverage with the type 2 diabetes prevention program, and as you're aware, the program focuses on individuals with pre-diabetes, so already at high risk. We have then expanded. We've had over 1.3 million people now referred into the program. And what has been, I think, particularly reassuring and pleasing is that over the last 2 years, we've seen the evaluations, both, we've published our own evaluations, but the NIHR were very kind in supporting an independent evaluation performed by the University of Manchester, objective, of course, as an independent evaluation. And they have shown very clearly in published outputs now reduced incidence of type 2 diabetes, both in participants, but they've also, and I must say, I didn't know that we would necessarily achieve this, but delighted that we have. They have been able to show reduction in incidence of type 2 diabetes at English population level as the programme sort of touched different parts of the country in the 3 waves of expansion. So between sort of 18 and up to the 2018 and the start of the pandemic, they were able to very clearly demonstrate reduced incidence, not just in participants, which is great, but at English population level as well. So fundamentally, it does what's written on the tin, which is, just very nice, given that that's been a 9-year undertaking on my part and the team's part. So, so that's been very nice.
Yeah, that's a massive achievement.
So that sorry, you did ask. I talked incessantly then on. You asked for. Did you ask for my 5 achievements? So I think I'd put that right up there. That probably is top of the list. Actually, well, my second achievement. I mean, this is probably equal because the first couldn't have happened without the second, and was the fact that I was appointed into a role, really, as I say, as a one-man show. There was no resource initially. I had no team, I had no work streams, and I had to build really from scratch within a new infrastructure, which was the NHS in England following implementation of the Health and Social Care Act 2012. And slowly but surely, I suppose, exploiting the opportunities that befell, certainly the funding opportunities. And my 10.5 years in post have been punctuated by funding opportunities, and you have to be ready. You have to be ready with a good narrative, with a strong case for what will potentially work, to improve the health of our people out there, the diabetes and the obesity communities. So firstly, we have to be ready with something that we think will work. Secondly, we need to have a very strong case in financially constrained times, really, which has been the case to some extent all the way through. And you have to have a plan that will not only benefit people out there from one's communities, substrate populations, if you like, but also with the potential to support sustainability of the NHS. And so return on investment from certain pieces of work were very crucial to arguing the case and getting it across the line to funding. And so establishing or making the case for return on investment is quite a tall order. It's much more challenging than just cost effectiveness, which is what NICE evaluate, for example. But to actually go that step further and say that the NHS can potentially save money in the long term was where the bar was set, certainly, in those early few years in post and subsequently, actually. And so we were able to make the case in certain specific areas for return on investment. The diabetes prevention program was certainly one, but we also made the case for a number of other work streams. And now roll the clock forward a decade. By last year, we had a sizable diabetes team with a sizable annual budget with 12 to 15 different work streams. So certainly starting from scratch on my own, I now find myself in the midst of a large, well-resourced team, actually, with many different work streams. Remiss of me not to also mention, of course, the achievements in the obesity space. And we have, while it took longer to get traction around dedicated work streams for obesity management per se, we achieved that a little later. The first strategic published output was the 5-year forward view. But then, of course, a few years later, we had the NHS long-term plan published in the early part of 2019. And using with the same approaches of things that would potentially benefit people out there in our communities, and also following the principle of potential for return of investment and sustainability of the NHS, we were able to land in the long-term plan a number of work streams that saw the creation of a separate second team, if you like, the NHS England obesity team, with dedicated work streams. And so over the ensuing 4 years, we've also established a well-functioning, decent-sized obesity team with dedicated work streams. For example, our digital weight management program. And we've actually now established a national obesity audit, following the example of the national diabetes audit that was created 20 years earlier by the sort of concerted efforts of Bob Young back in the day. So yes, so I think my second big item would be establishing the teams and the work streams that we now have, which really were from scratch. So I'm only on number 2, aren't I? Let me go to number 3. I think the third issue, which has been part of our developed infrastructure to support everything that we've done, is the use of real world data and national data sets, harnessing the power really of real world data, collecting data on everything we do, all of our work streams, ensuring that we therefore have data and power in numbers to effect a decent evaluation of everything that we've been doing. So use of real world data is right up there. And of course, that really took on a life of its own in the early weeks of the COVID-19 pandemic, when utilising the National Diabetes Audit, which is a fully comprehensive register, if you like, of everyone with a coded diagnosis of diabetes across the country, we were able to link that with another number of other data sets, including Office for National Statistics death registrations and the COVID patient notification system, which enabled us to do some epidemiological analysis in those early days of the COVID pandemic that proved to be world firsts, actually. So we were able to disentangle the excess risk for people with diabetes by type, so separately for type 1 and type 2 diabetes, of COVID-related mortality. And those were world firsts, published in high-impact journals. We had paired publications in the Lancet Diabetes and Endocrinology early on in pandemic times. And so I think, you know, the use of real-world data, therefore, our cardinal function, of course, is applying real-world data and national data sets to support quality improvement for better care delivery for our patients across the country, number one, but also for that crucial epidemiological analysis that supported, you know, world-first observations during pandemic times. So that would be number 3. Number 4, I think we've been very effective and ready always to exploit the potential funding opportunities that have come over the hill. You never quite know exactly when they're going to come, but you always need to be ready. I've already mentioned the opportunities thrown up by the strategy outputs, the 5-year forward view and the long-term plan. We had a marvelous opportunity in 2015 around the transformation funding pot, which is a term that's been bandied about ever since 2015, really. And, you know, we secured a number of lines of funding for things like better access to structured education across the country, additional investment for achievement of treatment targets and better routine care delivery around care process delivery for people with diabetes. We saw more resources for us to be able to improve access to multidisciplinary foot care when required. And we've now pretty much achieved universal coverage across the hospitals in England over ensuing years since that transformation funding was first made available. And fourthly, exactly the same for better access to diabetes specialists. Nurse input for inpatients with diabetes was also funded in those early days of the transformation funding way back in 2015. And again, we're pretty much at full comprehensive coverage of inpatient specialist nurse teams to support people with diabetes during their sort of inpatient journey. So, I think being ready for those funding opportunities, I think have been big things, really important, and certainly something that I would be advising my successor to be ready for. You never quite know when the next funding opportunity will arise, maybe a little while from this point in time, but it will arise at some point in the future. And finally, I think some of the other work streams really important. The remission program, we will be achieving, I think probably the world first to achieve again full geographical coverage of access to a type 2 diabetes path to remission program. And we've also been able to support, I think, with new programs, very new programs, actually, in the latter couple of years, programs that I see address the needs of the future. And the two cardinal ones, I think, are our work around multimorbidity. And I have to say that that's multiple long-term conditions. That's the clinical reality for us clinicians in all of the environments that we practice. In my complications clinics, for example, people generally are attending, for example, my foot clinic, not just with a foot ulcer, but they've got heart failure and peripheral edema because of that. They've got impaired renal function. They may have cognitive impairment from cerebrovascular disease. That is the clinical reality in our complications clinics. It's the clinical reality, I'm well aware, in general practice, and it's the clinical reality of the people coming through the doors of A&E into hospital as well. So multimorbidity, we have established a work stream. I have to say, while I'll be stepping down from the National Clinical Director role at the end of this month, I will be carrying on leadership in the multimorbidity work that we have established. And the second area that I think is really important, and we've announced launch of a piece of work only in the last few weeks, and that is, one of the most concerning issues for the future, I think, which is young onset type 2 diabetes. We do have now a work stream that we launched just a few weeks ago in that area. And, we're seeing younger and younger age of onset. I may have looked after the grandfather who was diagnosed at the age of 65 in my clinic over the years. Then I was looking after the mother, diagnosed at the age of 46. And now, unfortunately, I'm also looking after the granddaughter or grandson, let's say, diagnosed at the age of 28. And that's the real clinical reality. We're seeing younger and younger age of onset generationally. Those manifesting young onset type 2 diabetes, much more likely to come from deprived areas of the country, much more likely to see overrepresentation of South Asian and Black ethnicity, and interestingly more, whereas generally we tend to see a slightly higher proportion of men than women with type 2 diabetes. In younger onset, it's the other way around, slightly more women. And of course, that's crucially important for preparation for pregnancy and pregnancy outcomes in women who have already at young ages type 2 diabetes. How's that? I've given you lots there, probably way too much, but buried in there, you could list 5.
No, that's great. And I bet you could carry on if
I can talk forever, so you have to cut me off if you need to.
No, that's absolutely fine. So there are some big achievements, so well done. Has there been any other highlights during your time in the role, maybe attending certain conferences? Has there been anything that stands out during the last 10 years?
Oh, lots. So many things. It's been the most amazing 10 years from many respects. There have been huge challenges as well, but it has been an amazing experience over a decade. Huge highs, some lows as well with significant challenges to overcome. But yeah, it's been a wonderful time. I think landing new policy is right up there. The 5-year forward view, the long-term plan, as I've already alluded to, the comprehensive spending reviews, where we've successfully sort of landed resourcing for new work streams. I think the highlight of the NHS, knowing that the NHS diabetes prevention programme actually does what's written on the tin, that was only 15, 18 months or so ago that we had that coming through. That was a real highlight, evolving the new work streams. You asked about conferences. Well, the diabetes, so I think a real highlight has been the collaboration across the system, but the close working relationship that we established over many years with Diabetes UK in particular has been phenomenally fruitful and productive, I think. And you might recall that certainly from around 2014-15, we had a triumvirate of organisations really pulling together, and that was NHS England, which is where I sit, with Public Health England, and crucially with Diabetes UK. So that was the triumvirate that brought together clinical thoughts, public health thoughts, and third sector approaches, which was phenomenally productive. And that has been a real highlight of the last decade, is working so closely with third sector colleagues. Diabetes UK, obviously, also with JDRF as well, certainly on some of the technological advancements that we've been able to achieve in the type 1 space, which of course Partha Carr has led so fantastically on as well. But the conferences, I think the Diabetes UK annual professional conference obviously is big. They've been so generous in giving us big spotlights. I recall Partha and I and Simon Stevens being on stage for the opening plenary a few years ago, which was a real highlight. And finally, am I allowed to say, it was so lovely being awarded my honour, my OBE, actually, in the 2019 Queen's New Year's Honours list. It was a great honour and privilege. So that's just a handful of highlights, but there have been many, many more, to be honest.
Perfect. So for anyone listening, I imagine everyone knows who you are, but if there is anyone that is listening that doesn't, how did you get into diabetes and obesity? Like, what was your career before taking this role?
So I qualified from Barts in London in 1990, and spent a good while, 3 years at what was called SHO level then. So you were quite junior members of the teams, but it gave you the opportunity to rotate every 3 years. To rotate every 6 months, and that was over a 3-year period through many different specialties. And in the early days, I loved the general medicine, and a big part of being a physician, a diabetologist, always has been the general medicine, and I really enjoyed that in the early years. But it took me a good while to rotate through many, and I was fortunate to experience many of the different specialties: neurology, gastroenterology, renal disease, you name it. I went through many, and it allowed me actually to choose the one I enjoyed the most. And the one I enjoyed the most was what I consider to be the most holistic one, which is diabetes. And diabetes, of course, it has huge public health implications because of its high prevalence. Certainly of the type 2, the type 2 prevalence is a significant proportion of the entire population. But the additional complexities and nuances of type 1 care versus type 2 care, the implications for individuals of a disease that can affect all of the organs and all of the systems of the body, is what really attracted me. So I through very positive choice, chose to go into diabetes, which of course is married with endocrinology. And then I trained across the Northwest London sector, actually, in diabetes and endocrinology and general medicine over the course of the 1990s. Did my research at St Mary's Hospital and Imperial College. with Robert Elkeles and Des Johnson, who continue to be great friends, allies, and mentors. And I was appointed to my consultant post, full-time NHS consultant, in 2002. I spent I think 11 years as a full-time NHS consultant, took on leadership roles progressively, clinical lead for the department. And then there were opportunities at regional level to lead across something called the Integrated Care Pilot, of which diabetes was a major focus in Northwest London from around 2010-11 through to 2013, which gave me that flavor of leadership. And sort of, I think as clinicians, we are trained to do the one-to-one, the doctor-patient relationship, which is a huge privilege. But the taste of population level health and what one can affect through system change and population level impact was really attractive, which led me to apply for the National Clinical Director role in diabetes and obesity when it was advertised in, I think, just before Christmas in 2012, and I went for it and obviously got it. And so, having spent 11 years as a full-time NHS consultant, I'm now at 10.5 years as National Clinical Director, half-time-ish in that role, and the rest of my time still doing a lot of clinical work. But all through that time, clinical research was an important part of my portfolio. I published a lot from my own specialty clinics, really. And before you ask what comes next, I'm going to tell you, if I may. And so the last year I've been wondering whether there's room for a third chapter in my sort of senior professional career. And I was keen to achieve that if it were possible, and I wanted that to be academia, an academic role. And I've been very fortunate of late, and so I've been appointed to clinical chair in medicine at Imperial College, which I will start at the beginning of next month. So a new challenge as Professor of Medicine. I'll be based on the Chelsea and Westminster Hospital site. So exciting new challenges for me lie ahead. But it's been such a wonderful decade, and I'll miss the National Clinical Director role terribly, but it does feel time for something new and new challenges for myself, and probably actually new thoughts and new ideas from someone new in post as well, I think would be healthy. So hence my next move.
So finally, have you got any advice for the individual who's going to take over from yourself?
Oh gosh, lots and lots. I think it's been an evolutionary process. One has to become effective in a role that is complex. It has political interfaces, it has public interfaces, it involves leadership across, communities, gaining buy-in, respect, credibility among clinical and academic peers. It's a complex role, and I would be delighted to lend as much of my learning and experience as possible to my successor so that they can cut perhaps some of the corners that I had to go around in order to learn the way forward, really. But I think there are lots of tips. I think listening to the voice of people in the community, people living with diabetes, people living with obesity, is really up there, really important. Working collaboratively with clinical colleagues, with the fantastic people and our teams within NHS England, and some of the other arm's length bodies, really, really important. And of course, working in a really constructive working relationship with one's third sector organisation, with Diabetes UK, I think has got us a long way and will continue to do so. So yeah, I've got lots and lots of advice. I've had a number of conversations with people who are interested in applying. Obviously, it's not within my gift to choose my successor, and I'll be very interested to see who that is. We should know fairly soon. and I will be there to lend as much advice and support as they need from me as the outgoing person.
Perfect. Well, thank you, Professor Valabhji, for speaking to us today. It's been amazing to hear what you've achieved during your time in the role, which has just been fantastic. So well done.
Oh, thank you so much.